Yeah, can everyone hear me? Am I audible to everyone? Just type in the chat box if so. Yeah, thank you so much. So we'll start with today's web class, a discussion on mediastinum and the basics of mediastinum. Again, request people to disable their videos. Yeah, so this will be a more of an interactive web class. So I'll be sharing a few images, and you're required to type in the chat box your responses. Okay, so this is the first X-ray of the day. So can you just type in the chat box what this could be? This is a chest X-ray, obviously. So what do you think it is? Can you just describe uh, the location of the abnormality? Yeah, I'm getting a few responses. Para-Hilar, mid-zone. Yeah, so whether this lesion is in the lung parenchyma or extrapulmonary, that's what I wanted to ask you people. So few feel it's a mediastinal mass, few are typing in that it's a hilar mass, and few of them that it is a lung mass. So yeah, so how do we differentiate when we come across a mass like this on a radiograph? How do we differentiate whether it is pulmonary mass or extrapulmonary mass, a mediastinal mass? So what could be the possible points? So what are the differences between a pulmonary mass and an extrapulmonary mass? That's what. Yeah, so if you have type broad base, silhouette sign, okay, Hilum overlay sign. Yeah, so after seeing so many x-rays that I could have in the past couple of years or a few years of my becoming a radiologist, what I have realized is, yeah, the basic essence will be the same, that a lung mass will form acute angles with the lung itself. Okay, it will project, it will appear like indenting the mediastinum, but it will be forming an acute angles like this particular mass is doing, right? Acute angles. And mediastinal mass will form obtuse angles. So if you can, that means a broad base towards the mediastinum will be a mediastinal mass. And anything that has acute angles with the mediastinum of the lung will be a lung mass. So that will be the basic essence. So anything else? Any other point? Yeah, so this is based on our findings, we saw that it has acute angles. So this is a intrapulmonary mass. Okay, this is an intrapulmonary mass. So we'll come back to this X-ray later on. So we'll go to the next one. Yeah, what about this? So where is the lesion? Is there any abnormality? If so, where is the lesion? Kindly stop your videos if they are running your personal videos. It's a big distraction. So what are the, yeah, so yeah, someone is writing a speculated lung mass. So how do we say in this particular, yeah, I am sure that you're pointing about to this particular lesion, right? So how do we say where is it arising from? Very difficult, right? Or is it in the lung, or it's a mediastinal mass? right? Paracardiac, someone has written. So what does that mean, paracardiac, whether it's in the lung or it's the mediastinal? Can we say, yeah, you are written parenchymal, perfect, okay, ill-defined. So one of the features that can help us in determining whether it's a lung mass or a mediastinal mass is definitely the irregularity. Okay, if there is along the lateral margin of the mass, if it's very irregular, okay, that indicates that it is infiltrating into the lung. So it does not mean that all smooth margin lesions are mediastinal. Like in the previous case that we had, if I may go back, yeah, this one, it was again a smooth margin lesion, but here it was a pulmonary mass. Based on the acute angles, we decided it's a pulmonary mass, and here, though actually it's more obtuse angles, so it doesn't hold good all the time, but definitely because of the irregularities that we are seeing along the lateral margins of the mass, there is definitely an infiltration into the lung, maybe along the bronchi, okay, which usually happens with central malignancies like a bronchogenic carcinoma, squamous cell variety, or a small cell variety, okay. So again, another point which may favor lung infiltration is the irregularity along the lateral margin. So this is another point, okay. So yeah, so this was the same case where we have a hilar mass infiltrating into the lungs. This was a proven case of small cell carcinoma of the lung. So this was a hilar mass. So what do you mean by hilar? So hila is the junction where the mediastinum, basically the bronchi enter into the lungs, the vessels and the bronchi. So it's like a junction of the mediastinum and the lung parenchyma. So a hilar mass can actually show both the types of presentations. Like it may appear as a mediastinal on certain based on certain signs, and definitely the infiltration, the irregularities, the infiltrates, the lung infiltrates will tell you that they are actually it is spreading around along the bronchi or the airways. So yeah, this is the third one. So what can this be? So you feel it's mediastinal mass, right? So yeah, why did you say so? Why do you majority of you feel it's a mediastinal mass? Broad based towards mediastinum. Okay, that's nice. So broad based or obtuse angles being formed here, right, on either side. So it gives you a hint that it is likely arising from the mediastinum. Though we already saw that this is not 100% true all the time, but definitely this is one of the more sensitive indicators or more specific indicators on a plane radiograph when we are talking about plane radiograph. So and if it is in the mediastinum, where exactly, how to localize, where is it located? Now, yes, we can see certain vessels here, right? And you can see the margin of the heart. So someone has written hilum overlay. One of you have written hilum overlay sign. So what exactly is a hilum overlay sign? Yes. So actually, when the original Felson, when he actually described many years back, when there was no cross-sectional imaging, also he had described all these signs then. Even in his textbook, many of you must have read, and at least I will recommend that you go back and read the older textbooks written by Felson. So he describes hilum overlay sign as when there is a mass lesion or a lesion, when the lesion is actually overlying and the hilum appears hiding behind the lesion. Okay, so that is why it is called hilum overlay. Usually when there is a cardiomegaly, okay, when just there is a chamber enlargement, or there is a pericardial effusion, there is always a slight gap between the cardiac margins and the hilar. The hilar is always lateral to the mass. Okay, when it is actually because of cardiomegaly or a pericardial effusion. Okay, so the hilar is always lateral to the mass, but if it is arising from the mediastinum, so the mediastinum actually it goes beyond the hilar lateral margin and can project beyond it. So the hilar will be appearing as though it is hiding behind or in front of the lesion. Okay, and most of the times, especially in this, can we try to find where is the lesion located, which mediastinum? Based on the findings here, anterior mediastinum, one of you suggesting. Okay, anterior mediastinum. So majority of you feel it is from the anterior mediastinum. Actually, if you see carefully, what is this line here? This is the para-aortic line. Okay, you can see that lucency here. All right, so this is the para-aortic line which is formed because of the descending thoracic aorta overlapping on the lung parenchyma. Okay, and here in this particular area there is a loss of this line. Usually it starts from the descending descending limb of ascending arch of aorta and reaches up to the diaphragm, this particular line, and there is now here we cannot make out this lesion, right? I mean the line, para-aortic line. So that means this particular lesion is in the same plane as the descending thoracic aorta, and in one of the mediastinal classifications this comes in middle mediastinum, right, or the posterior mediastinum in few others. So based on this we can say this lesion is in the same plane as the descending thoracic aorta. Okay, so that means either it's in the middle or the posterior mediastinum and not in the anterior mediastinum as many of you suggested. So this sign is also important when we have to describe a mediastinal lesion, right? And so this sign is called a Silhouette sign, the positive Silhouette sign, right? We must have heard. So what is a Silhouette sign? We'll discuss again in the next few slides about this. So the Silhouette sign is when there is a loss of delineation between two structures, right? Because either they are in the same plane or they are of the same density and the margins of each other are actually touching each other or they are overlapping each other. So three things are required for a Silhouette sign. One is the densities. They must be almost of similar density. They must be in the same plane, and the margins must be touching each other. Only then the Silhouette sign will be useful in identifying. Okay, so Silhouette sign we must have read when we talk about how to identify the segmental atelectasis, which segment of the lung is atelectic based on Silhouette sign. So same thing can be applied to mediastinal masses also to depict from which part of the mediastinum is the mass arising. Yeah, so what is this again? First thing that we have to say whenever we see a lesion is whether it is parenchymal or a mediastinal or extrapulmonary. Mediastinal, plural, it can be anything. In this case, we are thinking of a mediastinal versus pulmonary. So again, there is a broad-based. In fact, there are two margins here, right? There are two margins and both are having broad-based and obtuse angle towards the mediastinum. So this is the CT scan of this particular lady. Now we can see, right, this particular lesion which is enhancing, and there are a few non-enhancing necrotic areas, and there is again a loculated pleural effusion posteriorly. So these are that was the cause for the two lesions appearing on the radiograph, right, in the right hemithorax. So again, this was a mediastinal lesion. So based on this, again, we can say now we cannot make out in this particular X-ray the arch of aorta, neither the cardiac margin. So this is an anterior mediastinal mass, at least this particular one, right? So based on the Silhouette sign, we can further localize into which mediastinum it belongs. Other than that, there are many other signs which we'll discuss again. Yeah, so this is a slightly tricky one. Can anyone try this X-ray? The first few X-rays are for you to identify, and the next few slides I'll be just covering the theory part of whatever we have discussed till now, so that it becomes compartmentalized into so that we know how to differentiate. I'll be just taking out theory slides in the next few slides. So the first 5-6 are for you to describe. Yeah, someone has commented the widening of superior mediastinum. Ribs are expanded. Thyroid mass. Okay. Rib interspace distance. Yes, exactly. So someone has identified that. Yeah. Can you see that there is some lesion here, right? It's unfused epiphysis. So it's a child. Okay. So it's a child and there is a lesion here in the left hemithorax. Now, whether is it mediastinal or pulmonary? Yeah, you have got the answer already. That's correct. So this is again, if you trace it carefully, actually the lesions margin are extending much beyond. Okay. So again, it is silhouetting the paraspinal line here, and this is a posterior mediastinal mass, and definitely there is thinning of this particular rib, possibly due to erosions, and widened intercostal space posteriorly, right, on the left side. So this was definitely a case of neuroblastoma, especially unfused epiphysis, and this was a 5th year of life. In the first 3 years, it is the most common. So, and especially involvement of the ribs, a few subtle calcifications on CT scan. So this was a case of neuroblastoma. So definitely a nerve sheath tumor in adults is as good that we can see on the similar findings on an X-ray in an adult X-ray, right? Yeah. So now we will just come to the basic theory part of what is a mediastinum, how to differentiate, and all that stuff. This we have read in our anatomy classes, right? So mediastinum is what is mediastinum? Can anyone just type before I can just speak on? Mediastinum is a space between the two lungs, right, extending from the thoracic inlet to the level of the diaphragm. So it's as simple as that. And in anatomy, we have read that there is a superior mediastinum, the lower border of which extends from the Malleus tunnel joint to the T4 vertebra, right? And below which will be the anterior, middle, and the posterior mediastinum. What is important to note here is, in the anatomical classification, the anterior mediastinum is anterior to the heart itself. The heart, arch of aorta, right? And most of the great vessels, except the descending aorta, come in the middle mediastinum or the superior mediastinum. The branches of the arch of aorta are in the superior mediastinum, the heart, the arch of aorta, most of it, right? They are in the middle mediastinum, and the descending aorta, descending thoracic aorta, the esophagus, the vertebral, prevertebral space, they all come in the posterior mediastinum. This is an anatomical classification, right? So even I had this confusion. So many people have given many types of classifications, which one to follow. So there was always a doubt. So so we will try to solve this as we go ahead. Okay, we'll try to look at different types of classifications. And this is the most common classification we come across in our radiology, right? Again, by the great Felsen. So what he did was he just drew a line from the anterior margin of the trachea on the lateral view of chest X-ray, lateral chest X-ray, anterior margin of the trachea, and just it has to pass through the posterior margin of the heart. Anything anterior to this line is anterior mediastinum. There is one more line 1 centimeter behind or posterior to the margin of anterior vertebral margins, and between these two lines is the middle mediastinum, where we have the hilum, right, the trachea itself, the esophagus, even most of the aorta, all come in the middle mediastinum, interestingly, in this. And posterior mediastinum is mostly the prevertebral space that we talk about, correct? So this is a Felson's classification in which the heart is in the anterior mediastinum. This is anatomical classification in which heart is in the middle mediastinum. So don't get confused about any of this. In imaging, just try to stick to Felson's classification, right? Forget that there is a superior mediastinum which exists for radiology resident purpose, for learning purpose. We'll just stick to Felson's classification because it will help us identify the plane of the lesion. So just stick to this. And now there is another classification that has come up new in a new publication. So I'll just tell you about that also. But I think more or less Felson's classification we should follow to avoid the confusion. The heart remains in the anterior mediastinum and there is no superior mediastinum on imaging. So these are the mediastinal boundaries. So again, the Felson's classification, based on the Felson's classification, this is the anterior aspect of trachea, posterior margin of the heart is the anterior margin of middle mediastinum. And it's the same that I said in the previous slide. So this is the new classification, ITMIG classification. It's in a recent publication, I think it's in 2018. Some group of experts came out with this, where it is very similar to the anatomical classification. They have but removed the superior mediastinum. Again, there is no superior mediastinum. Instead of anterior, middle, and posterior, they started calling it as prevascular, visceral, and paravertebral. Okay. Paravertebral is very similar to the posterior mediastinum seen as per the Felson's classification, right? So need not remember this as of now, but better we know that this exists. So stick to this Felson's classification. Heart is in the anterior mediastinum according to this. Okay. So please remember this. So what are the mediastinal contents and all? So it depends on which classification you're following. Felson's classification, anterior mediastinum will have fat, lymph nodes, thymus, heart, ascending aorta. Middle mediastinum will have the trachea, bronchi, lymph nodes, and esophagus, descending aorta. And posterior will have mainly the soft tissues of the prevertebral space. And again, as we can see, the anterior mediastinal masses are the most common malignancies of all the three, and the common tumors are enlisted here. We'll just try to enumerate as we go ahead. So on a chest X-ray, what are the boundaries of the mediastinum found by, right? We should know this. This is a very basic radiograph, chest X-ray post-anterior view. So the most first will come to the right mediastinal border. From inferior to superior, if we go, we start with the right atrium forming most of the inferior cardiac, right mediastinal border, right? And then as we gradually go up, it will be the superior vena cava, right? And so this is called the cavoatrial junction, which is very important, especially when we have to locate the tip of the central venous catheter. And then as we go ahead, we form something called an arch of the azygous vein, and anything further up will be mostly brachiocephalic vein. Okay, the right brachiocephalic vein, superior vena cava, and the right. So this is still superior vena cava, and then the right brachiocephalic vein higher up. So we should know the margin is formed by right atrium, superior vena cava, and more higher will be the right brachiocephalic vein. So that is the right cardiac margin. The left, from inferior to superior, the first will, most of it will be the left ventricle, right? Only part of it from the left atrial appendage, marginally just beneath the left main bronchus. Okay, very difficult to find. Actually, if you can superimpose your CT scans, making it a MIP or something, you'll understand how a left atrial only the appendage part forms part of the margin, left mediastinal margin. And then there is the pulmonary artery, the aortic arch, and finally the subclavian artery, the left subclavian artery. Okay, so these are the margins. Interestingly, right ventricle doesn't form any of the margins on a PA view. So we should know this. Where is the azygous arch? Where to locate the azygous arch on a PA view, right? So carina, these things are important. And on a CT scan, this is a very important thing which many students actually fail to answer, we have to try and identify the structures at various levels of mediastinum, right? This is the supraaortic level, much beyond the superior to the aorta. From right to left, you can, if you can remember, that will be the easiest. The left, the right brachiocephalic vein, the innominate artery, right? The other brachiocephalic trunk, whatever you may call it, the left brachiocephalic vein. These slides are directly the images are from the Web and Begins textbook. The left brachiocephalic vein, and these three are the branches of the arch of aorta, the innominate artery, the left common carotid, and the left subclavian. The esophagus is slightly on the left side of the midline. There is a trachea here, right? Anything in front of these vessels is called the prevascular space. Anything in front of the trachea is a pretracheal space. So these many things we have to remember, and we have to remember at least multiple levels. So almost just inferior to this level we have here the left subclavian vein that was seen here, now just going anterior to the innominate artery, and finally it will join with the right brachiocephalic vein to form the superior vena cava. So next is at the level of arch of aorta. So this is the arch of aorta, and there is a superior vena cava here, right? Now both the brachiocephalic veins have united to form the superior vena cava. This is the arch of aorta. You can see part of the azygous vein, which is almost like it is it's going to form the arch, and this is the trachea. Esophagus is collapsed, lying in front of the vertebra. This is below the level of arch of aorta, at the level of aortopulmonary window. Just beneath the arch of aorta, we find the aortopulmonary window. Again, we can make out the prevascular space, the superior vena cava, right, and anterior and posterior limbs of the azygous arch, just above the right main bronchus. So at the level of arch of aorta, almost we find the carina, right? So that is what we have to remember, and we cannot falter in identifying these structures as radiologists. We should know, even here it is labeled, this is from Web Begins, otherwise we should know even in exams or when we are discussing, I mean, when we have to comment on cases, we have to remember these structures. This is at the level of pulmonary artery, one below what we below the previous level. Again, there is already bifurcation of the bronchi that we can make out. The right main bronchus, left main bronchus, the esophagus in the midline here, the pulmonary artery divided into right and left, the ascending aorta, the descending aorta, the superior vena cava. See, the superior vena cava is always posterior to the arch ascending aorta. So just posterior and to the right. So that is what we need to remember. This is at the level of the aortic outlet, the aortic valves, right? Now, so instead of superior vena cava, we have the right atrium here. The pulmonary artery further goes down to drain into the, to the right ventricle. And here we have the left atrium from which we are seeing the pulmonary veins. This particular area is called the azygoesophageal recess. We can see this is the azygous vein and this is the esophagus, and this is what we call azygoesophageal recess because of its there is a lung parenchyma which is going to delineate this margin on a chest X-ray. We'll discuss that in the next few slides. So first thing, we discussed many cases till now. So how do we differentiate a mediastinal mass from a lung mass? Yeah, it remains standard. The first thing will be a broad base or an obtuse angle with the mediastinum. If it is there, then it is a mediastinal mass. Second, I would personally prefer to add this: if there are any irregularities or lung infiltrates, think of either a mediastinal lesion infiltrating into the lung or a lung lesion itself, like a bronchogenic carcinoma or a small cell carcinoma. But a smooth contour is most often seen with the mediastinal mass. The lateral margin, if it is smooth, it is more likely to be mediastinal, and if it is irregular, it is more likely to be a lung lesion. Obviously, mediastinal masses, we don't expect to have air bronchograms, and if the mass is bilateral, so it is going on both sides of the midline, it is a mediastinal mass. Bony and soft tissue changes, especially the posterior mediastinal mass, are more commonly do it, but even lung malignancies, if they have an extrapleural invasion, can cause bony infiltrations. Hilum overlay and convergence signs can help to some extent. Hilum overlay we already discussed. Again, I'll be repeating it again. Cervicothoracic and abdominothoracic signs, right? Silhouette sign, I personally feel this will help us a lot, especially in locating the mediastinum. Mediastinal lines and stripes, we'll discuss it again. So any lung mass, this is from radiology assistant, this image, any lung mass which is will indent the mediastinum and form acute angles, and any mediastinal mass will indent the pleura to form obtuse angles. So this is how we can differentiate. Another example, there is a mass lesion here and it is forming acute angles. So this is a lung mass, and here it is forming obtuse angles, this particular lesion. So it is likely to be a mediastinal mass. So now based on that, this is the one of the x-rays that we already discussed, the second or the third slide. So now can we tell where is it arising from? Sorry. Okay, so the confusion remains, correct? So mediastins, I again told you the lateral margins are irregular. So that means there is an infiltration into the lung, and it's located in the region of hilum. So it is on a chest X-ray, we can safely comment that it is a lung parenchymal mass, most likely a malignancy like a bronchogenic carcinoma. Okay, so again, this lesion, it was more straightforward. The angles are not that obtuse, and we can always make out the irregularity of spiculated margins laterally. So what about this? The same X-ray that we saw earlier, obtuse margins, right? So it's a mediastinal mass. And here we will again discuss the hilum overlay sign. The hilum appears to be hiding behind the mass. So, right, we can see the vessels traversing through the lesion. So originally Felsen described it to differentiate cardiomegaly from a mediastinal mass. He told that the hilum always lies lateral to the cardiac silhouette, okay? But only a mediastinal mass can actually overlay or overlap it. So if there is only a cardiomegaly, still the hilum will continue to remain lateral to the silhouette of the cardia, okay, or within 1 centimeter of the lateral margin of mediastinum. One more sign that that was the hilum overlay, and this is a positive hilum overlay sign when with the mediastinum, when the hilum is hiding behind the mass. This is a positive hilum overlay. One more sign that we can make out is there are few vessels coming here, right, and they are parallel to each other, correct, at the lateral margin of the mediastinal mass. So this is what is described as a hilum convergence sign. So again, hilum convergence sign is to differentiate between a hilar lesion, particularly pulmonary artery enlargement with a mediastinal mass. Okay, if pulmonary artery enlargement was to take place, these vessels would have converged at the lateral margin, not be parallel like this. Here they are parallel. So even if you want to call this a hilar mass, it is not arising from the pulmonary artery. Okay, and we already know that it is forming obtuse angles with the mediastinum. So it is a mediastinal mass and not pulmonary arterial enlargement. So that is hilum convergence sign for you. And I already told the silhouette sign, it is silhouetting the para-aortic line, para-aortic stripe. Okay, so it's in the posterior mediastinum. So this we have already discussed. So this is the principle of hilum overlay and hilum convergence signs. Okay, so if you can just read it. Yeah, now let's talk about some further anatomy, which may help us to differentiate again the various compartments of mediastinum the lesion will belong to. So this X-ray is showing a line here, right? In the center, almost at the level of D5 vertebra downwards, right? And there is another line here in the center. Again, it is located in the center, overlapping the tracheal air column, and it is much higher than the previous line. So the lower one is the anterior junctional line. Okay, it is just short, right? It starts below the level of the lower part of manubrium. We can say manubriosternal junction. Manubriosternal junction below that. Okay, the anterior junctional line starts and it crosses the midline just to the left and ends here. It's a short line again. So this is called anterior junctional line. So if you see this image, the anterior junctional line is formed. There is a boundary, right? There is the two pleura, both layers of pleura are meeting at the midline anteriorly at this particular level. So the lungs on either side will create a distinct line on the radiograph. And remember, that is always below the level of the manubrium of the sternum. Okay, and there is another line I told you. So we can see this line, which is much higher. This always ends at the level of the aorta. Okay, it doesn't extend below the level of arch of aorta. So, and again, it's a short line. This is called the it's slightly thicker as compared to the anterior junctional line. So this is a posterior junctional line. Here we can see what is it formed because of. Again, there is a thicker pleura, layers of pleura behind the esophagus and lung, air in the lung on either side, which is gives a distinct linear shadow like this, okay, opacity like this. Posterior junctional line and anterior junctional line both are seen in hardly 20 to 30% of the cases. So don't worry if you're not seeing it, it may be actually not seen. So we usually only see it in 20 to 30% of the cases, but they may be helpful if seen. If it is located like this, then it is normal. Posterior junctional line may be thickened in cases of posterior mediastinal masses, right? Even anterior junctional line can be thickened in anterior mediastinal masses. Another thing that we can see here is this particular stripe along the right lateral margin of the trachea. This is called right paratracheal stripe. Okay, so this is formed again because of the tracheal air column. This is because of the tracheal wall. Either side of it is the trachea. One side is the tracheal air column and the other side is the lung. So this particular line is seen as a linear opacity here, and this is called right paratracheal stripe, which should not be more than 4 millimeters. Okay, up to 4 millimeters is acceptable. More than 4 millimeters, it can be lymph nodes or tracheal malignancy, right? Many other causes for it, which we'll not discuss now. Yeah, so what is happening here is this X-ray basically was to show you the something called azygoesophageal recess. So you can see something in the midline here, a thick line is going almost curving slightly towards the right side of the superior aspect and going down almost till the level of the diaphragms. So this actually starts from almost the level of arch of azygous vein. So this is called azygoesophageal recess. So this is how it appears. And again, this is located in the middle mediastinum based on Felson's classification. This is, we can see the azygous vein here, the esophagus, and this is the line. Okay, if the esophagus is filled or dilated with air, actually instead of single line, two parallel lines can be seen. So that is okay. That only tells you that both the esophageal walls can form either each line. Okay, so if this is displaced, it is likely due to displaced or thickened mediastinal mass is the possibility. Again, this is seen in 30 to 40% of the cases, not all. Reiterating the same thing, the paratracheal stripe, right side. Left paratracheal stripe is not discussed in Sutton, but Webb and Higgins mention about it. Sutton says that the tracheal left wall doesn't directly overlap the lung, so there is no left paratracheal stripe described. So a few more stripes here and lines which can help us. Just besides the vertebral margins, okay, the vertical linear bands are seen. These are called the paraspinal lines. Okay, one on the right, one on the left. The left is more consistently seen. Usually the left paraspinal line is medial to the para-aortic line. This is the para-aortic line, and we can, again, the left paraspinal line is thicker as compared to the right. So this is what we need to remember. And both these lines, if distorted or thickened or deviated, indicate a posterior mediastinal mass. So this is for the lines. Again, the relationship between the the lower one is the anterior junctional line, the superior one is the posterior junctional line. This is how they appear. Anterior junctional line, posterior junctional line again. Yeah. Oh, now what can this be? Based on this chest X-ray, what is the abnormality? Okay, so I thought I showed you the next image. This is the, based on this image, can you just refine your findings? Yeah, there is a, it looks like an enlarged cardiac silhouette, right? And definitely a pericardial effusion is a possibility if we just take a look at the anterior, chest X-ray frontal view. Now there is, on lateral view, as rightly pointed out, there is an obliteration of the retrosternal space also, right? So what does that mean? So the cardia is located in the anterior mediastinum, we told, and now the retrosternal space is also obliterated. So there is some silhouette sign taking place in the anterior mediastinum. So it turned out to be a anterior mediastinal mass, right? And this was actually a thymolipoma. This is again taken from one of the articles published recently. So it need not always be a cardiomegaly, right? So that's one thing I learned from this. And we should always think of an anterior mediastinal mass also. So better do a lateral view at least to just know what is happening. And again, this is the importance of understanding the silhouette sign. Yes, again, where is the lesion? The first thing whenever you see a chest radiograph, a lesion in the chest radiograph is to identify whether it's intrapulmonary, mediastinal, or extrapulmonary. It can be pleural, mediastinal. So what is in this case? Okay, fine. So it's a mediastinal mass. Perfect. It's a mediastinal mass. These are just examples. I will not give you the final diagnosis here. We will again discuss it in the next class. Okay, when we do a case discussion on these. Definitely, it's a mediastinal mass. Now I can say this, right? It's smooth margins, obtuse angles. Okay. And also we can see that the Hilar, they're not converging the vessels along the lateral margin, so it is not arising from the pulmonary artery also, right? And it is silhouetting the ascending aorta. So you can always localize it to the, and part of the cardiac margin also, the anterior mediastinal mass. Okay, so this is how we should identify. Here again, we just, whatever we discussed till now, anterior mediastinal, right? Because it was silhouetting the cardiac margin and ascending limb of arch of aorta, and now we have a retrosternal space which is obliterated, right? And this is how it appeared on a CT scan. So this is what it was. So most common thyroid mediastinal abnormalities, anterior mediastinal abnormalities. So there are some T's and all, the 4 T's everyone must be aware of. thymus, thyroid, lymphomas, germ cell tumors, more common, right? So thymus abnormalities, especially thymoma and all, are seen in elderly individuals, 50s and 60s. Lymphoma is possible again in elderly, even in youngsters, children, right? Germ cell tumors are very common. Retrosternal extension of thyroid is another possibility. So individual lesions, we'll try and keep it as case presentations. We will not go too much into depth, otherwise we'll not be able to cover in this lesion, or you can do it as a self-study, that's better. Okay, so we'll try to understand how to approach a lesion in this class. So based on the location of mediastinal masses here, this is from Sutton. So he tells that area number 1, 2, and 3 depicted in the image are anterior mediastinal lesions. Based on that, the differential diagnoses are given. It's there in Sutton. You can go back and have a look. Based on the locations on a lateral radiograph, you can try and identify the lesion. So the anterior mediastinal masses, these are the signs to identify. Okay. So one is the Hilum overlay sign, right? So that we saw in the original case, right? The case that we discussed, where then the displaced anterior junctional line, obliterated cardiophrenic angles, obliterated retrosternal clear space on the lateral chest X-ray, effacement of ascending aorta. So most of it we discussed. Another example, so bilateral in a child, bilateral lesion, anterior mediastinal because it's still outing the cardia, right? And aorta, so it's anterior mediastinal lesion. So it is, in this case, it was a benign thymic hyperplasia. What is this? Where do you localize the lesion to? First thing is intrapulmonary or extrapulmonary. So once it is extrapulmonary, that means mediastinal, yeah, right. So it's simple. So this is just like it's silhouetting the cardia, so it's the anterior mediastinal mass. And there are some calcifications. So there are lesions, specific lesions which show calcifications. So we should know that, including a thymic carcinoma, a thymoma, which can show you seminomas, right? Very commonly teratomas. So we should be able to give the differential diagnosis based on the age group and other appearances. So mediastinal masses which contain fat, these are some of them. Yes, what is this? Okay, so we can see that again there is a lesion along the mediastinum, right? Broad based on the right side. It is contiguous with the ascending aorta, and this is a case of ascending aortic aneurysm. Okay, so we should remember this is also a possibility. Okay, one more for you. Which mediastinum is the lesion located? We know that it's a mediastinal lesion because smooth margins, obtuse angles, right? Even we have the Hilum overlay sign, right? So it is anterior mediastinal mass. Yeah, perfect. Pericardial cyst is a possibility, and this was a pericardial cyst. What about this? Where is the lesion? Okay, good. So fine. Yeah, so what's happening here is there is a lesion, correct, which is projecting. It's a mediastinal lesion based on the findings of obtuse angle, broad base towards the mediastinum, smooth margins, and we can see that there is a widening of carina. So someone pointed out that it was a bronchogenic cyst. So it is in the, see that it is not silhouetting the cardia, right? It is not silhouetting the even ascending limb of the arch of aorta as of now, right? But definitely the subcarinal angle is widened. So this is one of the signs of a middle mediastinal mass. So this was a middle mediastinal mass. In that case, it was a bronchogenic cyst. As rightly pointed out, subcarinal location is the most common. It can also be a lymph node. Remember, subcarinal enlarged lymph nodes are always a possibility. So these are the common masses that we come across in the middle mediastinum: the lymph nodes, bronchogenic cyst, right? Even CA bronchus, if it is a central bronchus involving the main bronchus, right? So why not posterior? Someone asks. So why posterior is what I ask, right? What are the findings that are telling you that it's in the posterior mediastinum? You can see classically that the right. You can see the subcarinal angle is widened and the anterior are spared. So once you already have a localizer, why do you want to think about anything else? So don't go by just that obviously it is not arising from pulmonary artery doesn't mean it's not in the middle mediastinum. Remember that. So again, common causes in the middle division based on its location. It's again given in Sutton. Please have a look at your textbooks. So the middle mediastinal lesions, how to identify: widened paratracheal stripe, displaced azygoesophageal recess, widened carina, para-aortic stripe thickening, AP window masses, and again the silhouette sign, which will tell you that it's not in the anterior and the posterior mediastinum, right? Yeah, what about this? Why posterior? No, don't go to the diagnosis. Just try to describe the location. It's a mediastinal mass, I'm telling you. So why posterior? Why not anything else? So someone says it's in the anterior. So why not anterior is because there is no silhouetting of the cardiac margin here. If there was silhouetting of the cardiac margin, it would have been anterior. Now it is not silhouetting the cardiac margin, so it is behind the heart. Yes, so someone pointed out rightly the paraspinal line is what is getting disturbed here, right? We can't make out delineate the paraspinal line on the left side. So that tells it's likely in the posterior mediastinum, correct? Next case for you. Yeah, there is definitely a mass lesion. So, okay. So you need not give the diagnosis as of now. Just tell, okay, yeah, most of you got it. So this is an interesting case. There is a lesion here, the right side, even in the left side. Other than the aortic arch, also you have a bulge here, right? So both the paraspinal areas, the lines are not, they are deviated. Fine. So because of that, and bilaterality indicates it's a mediastinal lesion. Obviously, it's a mediastinal lesion and it's in the posterior mediastinum, and there are causes for bilaterality of the mass, right? So there can be bilateral paravertebral abscesses, as was in this case, correct? There can be extramedullary hematopoiesis, very similar looking achalasia can be there. So bilateralities, again, differentials we are supposed to know, okay? On the lateral view, we can make out that the disc is involved. So it was a case of spondylodiscitis with bilateral paravertebral abscesses. Now, what is this? So can you call it a mediastinal mass or a lung mass first? Okay, it's a mediastinal mass. Note the, so now don't go by the acute angles, right? They may not always hold good. You may still try to argue out that it can be a lung mass, right? Because of the acute angles. And I don't think that's the wrong thing also, but this is a smooth margin mediastinal mass. We can see it is going above the level of the clavicles, correct? It's a large mass, that's what we can say. Even the paratracheal stripe, we can't make out clearly, so it is definitely there in the middle and the posterior mediastinum. Yeah, what is happening here? These are just for practice, okay? Don't worry about the diagnosis. We should know how to tell if whether it's mediastinal or versus pulmonary, and try to locate to which mediastinum they may be. Yeah, definitely this lesion is not in the anterior mediastinum, right? Everyone agrees to that. So why posterior? Why do you feel it's a posterior mediastinal lesion? Why not a middle mediastinal mass? I would say still it is a possibility in this case, middle oblique posterior. So every time need not be that we will be exactly able to localize. Is an example of that, right? This can be either in the middle or the posterior mediastinum. This was in the posterior mediastinum, as rightly pointed out by many. So where is the mass? Okay, so this was the mass lesion, right? So usually when you see in a lateral X-ray, there should be increasing lucencies as we go down, the increasing vertebral lucencies as we go from superior to inferior. Here there is a slight opacity which corresponded to that particular lesion. Okay, so this was, I personally feel you should, if possible, someone is asking whether we can comment directly posterior or medial and anterior view. There is no fun if we can say, if you just say mediastinal mass and leave it, right? So we need to investigate a little bit more. If you can get those subtle signs which are indicating to a particular mediastinum, then why not go for it? You can always confirm with a CT. It's all learning experience. If we don't know to comment, then it becomes a problem, right? Definitely. You can tell this more likely in a middle or a posterior mediastinum and ask for a lateral view. There is no problem at all. You have to ask for a lateral view, and you are right. New guidelines on CT. Sure, yeah, you have to use it. That's not at all a problem. And these are basically being described on a chest X-ray. Okay. When it comes to CT, we'll discuss that. Maybe not in this class, but sometimes. ITMIG is not that popular still. Okay. Basically, it's the same. If you feel that if you have to classify heart masses as middle mediastinum, then the only thing is you will only know that the lesion is in the plane of the heart. Whether you keep it in anterior mediastinum, middle mediastinum is a different issue. If there is a silhouette sign with heart, it only means that the lesion is of the same density of the and in the same plane as the heart. That's all it says. So I don't think personally that it is going to change anything to follow the older ones or the newer ones. It's okay, but just stick to whatever you want to follow. That's all. I personally prefer stick on to Felson. Still, ITMIG gets more popular. Yes, this is again another one. Last few slides. Yeah, I think we should stick to Felson as long as we are residents, and as we get to know and gain some expertise, we can always switch on to other methods of mediastinal classification. So it's neither in the anterior mediastinum, right? The paraspinal line comes in the middle mediastinum according to the Felson's classification. So it is not, sorry, the para-aortic line. The para-aortic line is in middle mediastinum according to Felson. So this is not in middle mediastinum also, likely to sell out in the paraspinal line. So it is in the posterior mediastinum. Okay, so this is the para-aortic line, which is not getting silhouetted. So it is not in the plane of the descending thoracic aorta, which is a part of middle mediastinum according to Felson's. So this goes on into the posterior mediastinum. So we can easily localize which mediastinum just based on the silhouette signs, right? So this is what it was. It was a case of again a nerve sheath tumor in an adult. So these are the common posterior mediastinal masses, the neurological, the nerve sheath tumors in adults, neuroblastoma in children, right? Neuroenteric cysts, and even the lymph nodes, paraspinal abscess, extramedullary hematopoiesis. Though it is written esophageal duplication cyst and descending aortic aneurysm, usually they, according to Felson, they come into the middle mediastinum. So just don't get confused with this, okay? Yeah, please. Silhouette sign plays a major role not only in identifying the atelectatic segment of the lung, but also to identify the location of the mediastinal mass. So again, the Sutton picture here, you can just go back to your textbooks and have a look. I will not be describing much here. So the signs to identify, what is a cervicothoracic sign? Yeah, we didn't discuss only this point, I guess. What is a cervicothoracic sign? It's not just that the mass is extending above the level of clavicles. So first thing we'll understand is the anterior mediastinum is below the level of clavicles. There is no anterior mediastinum above the level of clavicles. Okay. So if there is a mass which is extending above the level of clavicles, right? Either it's in where exactly? Either it can be a skin mass, right? Superficial structure. It can be in the neck, correct? It can be the neck. It can be in the posterior mediastinum. So what cervicothoracic sign says is, if a mass lesion is extending above the level of clavicles and there is a well-defined border, well-delineated border also extending above the level of clavicles, that means it is lined by air. So this is cervicothoracic sign positive. So this means it is in the posterior mediastinum. Okay, it's as simple as that. So it is lined by air. Posterior mediastinum extends well superior to the level of clavicles. So if there is a well delineated lateral margin of the mass extending above the level of clavicles, it's in the posterior mediastinum. That's what it says. So again, some mediastinal signs are shown here, the hilum overlay, and right. So just stick to this. Yeah, this is another example of a cervicothoracic sign. This is taken from one of the articles. So sharp margin extending above the level of clavicle. It is a, not only the mass should extend above the level of clavicles, the margin should be sharp. Please remember. Otherwise, it can be even a neck mass. It has to be lined by air, at least at the margin, like lined by the lung. Now there is another thing called thoraco-abdominal sign. So what does that mean? So if a lesion is extending, again the well-defined margin, outline of the mass is extending below the level of diaphragm. So where is it located? It is located in the posterior mediastinum. It can be located in the posterior mediastinum again because there is some air lining the mass. Okay, so likely that it is located in the posterior mediastinum. That's what it means. I mean, that is how it helps. So there is another connotation of thoraco-abdominal sign that I'll not discuss today. But as far as mediastinal masses is concerned, what we can understand is once we localize it as mediastinum and once we see a lesion extending below the level of diaphragms, well-defined margins, it is in the posterior mediastinum. So this is from the radiology assistant based on tissue composition. So we can have different lesions, right? If then first we have to localize the lesion to which of the mediastinum. Some masses can, if they are very large, they can extend more than one mediastinal classification, right? And then look for any, if there is any fluid. It's a pure cyst. There are some cystic lesions like duplication cysts, neuroenteric cysts, right? Bronchogenic cyst. And if it is a mixed fluid and solid component, think of anterior mediastinal, then think of thymoma, germ cell tumors, middle mediastinum necrotic lymph nodes, posterior mediastinum again nerve sheath tumor, and fat. These are the examples of fat we should know of, which are the lesions which contain fat. And vascular structure anomalies, right? Vascular abnormalities in each of the mediastinum are depicted here. So what all did we learn today? We learned, I hope all of you are with me, we learned something about how to differentiate a mediastinal versus a lung mass, right? And we learned something about anatomy of mediastinum, the stripes, the anatomy itself on a chest X-ray, right? Though I didn't discuss the lateral chest X-ray normal anatomy, that we will do it sometime, or please do it as a self study, right? It's very important. It's slightly tough, so maybe we'll include in one of the further classes. We also discussed the vascular anatomy on a axial CT, how to identify different structures, like different types of classification, and we concluded that till now, I think we should just continue with Felson's classification. And some important stripes and lines, all stripes and lines I didn't mention, and it is not required. So we only mentioned what are useful for us, okay? Signs, so we discussed some signs that can help us, like hilum overlay, convergence, silhouette signs, cervicothoracic, thoraco-abdominal, and how to localize the lesion to which mediastinum, and some common lesions in each of the mediastinum. So these are what we discussed today. I hope it was a useful class. I'll just try if we can answer some questions. I think I have a few minutes left. I'll just see the chat box now. So cervicothoracic sign is positive for a posterior mediastinal mass, or any even super neurofibromatosis arising from the skin. If it is outlined by the air surface, air outside the body, even that will show a positive cervicothoracic sign. So what is that? Yeah, positive cervicothoracic sign is anterior. No, positive cervicothoracic sign is posterior mediastinum. Thoraco-abdominal sign is posterior mediastinum, because only the posterior CP angles extend much below the diaphragms. The posterior part of the lungs, the posterior part of the lungs are the ones which extend much below the level of diaphragms, posterior CP angles, I mean. So they outline the mass better. So thoraco-abdominal sign is for posterior mediastinal lesions mainly. Hilar masses are mediastinal masses also. That is always a confusion, because I told hilar is the junction between the mediastinum and the parenchyma, okay, pulmonary parenchyma. So in exams, if you get a, you can just call it a hilar mass rather than calling a mediastinal or a pulmonary, unless they coax to do so, okay. Hilum is the junction. So, and if it is just lymph nodes, lobulated contour, smooth margins, you can still tell it is a mediastinal mass. If it has irregular lung infiltrates, you can tell it's a lung mass. So it's as simple as that. And a few more questions, I guess. Descending thoracic aorta is in mid or posterior. Felson says it is middle mediastinum. Okay, so the para-aortic stripe obliteration is a part of middle mediastinum. Then thyroid mass will still have cervicothoracic sign positive. If it is a difficult to say, it depends on the mass. Usually just a retrosternal extension of a nodule will not have a cervicothoracic sign positive. It will be, basically it will not have a well-defined lateral wall. Okay, it may be arising from the neck and going into the chest, but till it is outlined by air, the lateral margin is outlined by air, we cannot say it is positive. Hilum convergence sign. Okay, hilum convergence, if there is in a mediastinal mass at the lateral margin, the vessels appear parallel to each other. Okay, so that means it is a mediastinal mass. At the lateral margin, if they appear to converge towards one point at the lateral margin of the lesion, it is a pulmonary artery enlargement. That's what is the Hilum convergence sign, to differentiate between pulmonary arterial enlargement and a mediastinal mass. Yeah, hilum is a very confusing thing, because hilum is composed of bronchi, right? The bronchus enters. So if it is a bronchial lesion, it will definitely go into the lung and it becomes a lung parenchymal lesion like a bronchogenic carcinoma. If it is from the lymph nodes or pulmonary artery, we can safely still say maybe it is a mediastinal lesion, right? Lobulated, smooth margins, mediastinal, remember. Ascending aorta, heart, or in the anterior mediastinum. Yeah, correct. Yeah, hope it was a useful class, and we could clarify certain things, whatever I could understand based on my experience and study that I have done. If there are any lacunae, you can always suggest. I think it's just a part of discussion. We need to keep having more and more to understand better. So I hope it was useful for all. Thanks once again for joining us.